Welcome to this explainer. Look, if you or a loved one are relying on Medicare in 2026, or even if you're just getting close to that age, you are absolutely going to want to pay close attention today. We're going to completely unpack the complex, honestly, kind of dual-naturatured landscape of Medicare as we head into 2026. It is not the same system it was 5 years ago. There are some massive financial shifts happening, some really great and some, well, not so great. We are going to discover the exact financial changes, uncover the hidden coverage gaps that catch so many people off guard, and most importantly, we're going to arm you with smart, actionable strategies. The whole goal here is simple. We want you to avoid those devastating financial surprises that can literally wreck a retirement. So, let's jump right in. Right out of the gate, I have a really important question for you. Do you know the exact difference between skilled care and custodial care? I know it sounds like pure medical jargon, right? Like something buried on page 40 of a health insurance manual. But getting the specific definition wrong in 2026 could easily cost you upwards of $100,000 completely out of pocket. No exaggeration. It's one of the most common and frankly most dangerous myths in all of American healthcare. People just assume Medicare has their back for everything as they get older, and that is a very costly assumption. We are going to dive deep into this later in the explainer and uncover exactly how you can protect yourself from falling into this trap. So here's our roadmap for today. First, the 2026 Medicare cost changes. Second, surprising 2026 coverage gaps. Third, the nursing home trap. Fourth, navigating care outside the U.S. And finally, number 5, smart tax and financial strategies. Okay, let's dive into this. Section 1, the 2026 Medicare cost changes. Now, 2026 is actually bringing some highly anticipated financial wins for Medicare beneficiaries. And this is particularly true when it comes to prescription drugs. This is a huge deal. Under a new law, Medicare was finally given the power to actually negotiate prices on certain costly brand name drugs that don't have cheaper generic competitors. 10 medications were selected for this very first round of negotiations, and they treat some incredibly common conditions, everything from diabetes to cancer. And the numbers we're seeing brilliantly illustrate the new savings. I mean, the impact is just massive for the folks who rely on these daily. Let's look at a few examples to put this into perspective. Take the diabetes drug, Govia. It drops from a 2023 list price of $527 a month all the way down to a negotiated $113. That is a 79% discount. That's real money back in your pocket every single month. Then you have Farsa, another major drug, dropping 68% from $556 down to $178. But then look at the rheumatoid arthritis drug, Enbrel. This one is a real game changer. It sees a massive 67% cut. We are talking about dropping from over $7,000 down to around $2,300. That isn't just pocket change. That's literally the cost of rent or a mortgage for a lot of people slashed right off the top. Across these 10 medications alone, almost 9 million enrollees are expected to save an estimated $1.5 billion in out-of-pocket costs this year. It's an absolutely crucial shift in how Medicare handles high-priced medications. And keeping with the good news, I want you to really lock in on this number. $2,000. This is the new absolute annual out-of-pocket prescription drug spending cap for Part D enrolls in 2026. To give you some quick context, this cap was actually introduced at $2,000 back in 2025, and now it's been adjusted up 5% to account for inflation, landing us at $2,100. The existence of the ceiling is an unbelievable relief. For years and years, Part D plans basically had no absolute hard cap. You had the infamous donut hole and a percentage-based catastrophic phase where you were still paying indefinitely. It caused so many older Americans to literally skip prescription refills or cut their pills in half just to survive financially. It was a nightmare. But now, once you hit that $2,100 limit out of your own pocket, you are completely protected from any further out-of-pocket drug costs for the rest of the calendar year. Period. Whether your medications cost $5,000 or $50,000, your personal bleeding stops at $2,100. That gives you predictability. And in retirement, predictability is everything. However, we have to keep it real here. We have to balance those prescription wins with the reality of rising base costs. The whole system is kind of like a seesaw. While drug prices are getting reined in, the standard Medicare Part B premium, the part that covers your doctors and outpatient care, is increasing to $22.90 per month. That's a nearly $18 jump from the previous year. On top of that, the maximum Part D deductible, the amount you have to pay before your drug coverage even kicks in, is rising to $615. So, what does this actually mean for you day to day? Well, because most people have their Part B premiums deducted directly from their Social Security checks, these increases are likely going to eat right into your Social Security cost of living adjustments, or COLA. You might get a bump in Social Security, but Medicare reaches in and takes a bigger slice before the money even hits your bank account. So, it's a bit of a give and take that you really need to factor into your monthly budget. Section 2, Surprising 2026 Coverage Gaps. It is incredibly important to know exactly what original Medicare still won't touch in 2026 so you aren't caught off guard when you go to the doctor. A lot of folks think original Medicare, that's parts A and B together, covers basically everything from head to toe. It doesn't. It contains some staggering omissions for everyday health needs. First up, routine dental care. Cleanings, fillings, root canals, dentures, not covered. Now you might be thinking, but I see commercials all the time saying Medicare covers dental. That's usually Medicare Advantage. And while some Advantage plans do offer dental, they often cap those benefits at $1,500 to $2,000 a year. Anyone who's had major dental work knows that a single crown or an implant will eat up that entire $2,000 cap instantly, leaving you entirely responsible for the rest. What about your eyes? Routine vision exams and glasses are largely entirely out of pocket. Hearing aids, which are absolutely crucial for staying connected and can easily cost thousands of dollars per ear, not covered by original Medicare. Cosmetic procedures, as you might expect, aren't included either. But here's one that surprises almost everyone. Adult diapers and incontinence supplies. They are entirely excluded. Why? Because Medicare officially categorizes them as personal hygiene items rather than medical treatment. It's a huge ongoing expense for millions of aging Americans, and Medicare won't pay a dime toward it. You really have to plan for these gaps. And there's another coverage hurdle you definitely need to be aware of, especially depending on where you live. There is a new 6-year pilot program launching in 6 specific states: Arizona, New Jersey, Ohio, Oklahoma, Texas, and Washington. This program introduces something that original Medicare hasn't traditionally used a lot of: prior authorization. If you live in one of these states, you might now need prior authorization for certain medical devices or procedures under original Medicare. Now, the Centers for Medicare and Medicaid Services states this is intended to target potentially wasteful procedures and keep costs down. That's their goal. However, in practice, on the ground, what this actually means for you is that it introduces a brand new layer of administrative steps. It introduces red tape. Your doctor says you need something, but then you have to wait for Medicare to say yes before you can actually get it. This could potentially lead to wait times and delays before beneficiaries in these 6 states can receive certain care. It's just something you have to be mentally prepared to navigate. Let's move to and see how this builds into our next topic, Section 3, the nursing home trap. All right, we really need to slow down here and draw a hard, clear line between 2 terms that people use interchangeably all the time, completely unaware of how different they are financially. First, there is a skilled nursing facility. This is for short-term medical recovery. Think about going here for physical therapy after a major hip replacement. Or maybe you need a registered nurse to provide complex IV medications or wound care. It's purely medical, and it is meant to get you back on your feet. Medicare covers this under very specific conditions. Then there is a nursing home. A nursing home provides long-term custodial care. Custodial care basically means non-medical help with the activities of daily living. Things like bathing, dressing, eating, or just getting in and out of bed. Here is the absolute reality check. Medicare never covers long-term custodial care, ever. Assuming that it does, assuming that Medicare will just pick up the tab if you get old and need to move into a home, is hands down one of the most common and dangerous mistakes you can make in retirement planning. It catches so many families completely off guard. And honestly, even getting Medicare to pay for that short-term medical skilled rehab stay I just mentioned, that requires navigating a notoriously tricky exact sequence of events. It's kind of like an obstacle course. Let's walk through it. Step 1, you must have a 3-day consecutive inpatient hospital stay, 3 midnights. And get this, the day of your discharge doesn't even count toward those 3 days. Step 2, you must enter the skilled nursing facility within 30 days of leaving that hospital. You can't wait 2 months and then decide to go. Step 3, you must actually require skilled medical care that is explicitly ordered by a doctor. It has to be something you couldn't just do on your own at home. And step 4, if you successfully navigate all of that, Medicare only covers up to 100 days maximum per benefit period. It is a strict countdown. Now, days 1 through 20, those are completely free to you. But starting on day 21 all the way through day 100, you are hit with a steep coinsurance of $217 per day. Think about that. $217 a day adds up unbelievably fast. And after day 100, Medicare pays absolutely nothing. You are entirely on your own. And here is the exact spot where so many families get totally derailed. Beware of something called observation status. Let's paint a picture here. Imagine you're rushed to the hospital. You spend 4 days there. You're physically in a hospital bed. You're wearing a hospital gown. You're eating hospital food. Doctors are running tests on you left and right. Then you're transferred to a rehab facility to recover. A few weeks later, you open your mail and you get a massive bill from the rehab center, thousands of dollars. Why? What happened? Well, because the hospital quietly classified you as being under observation status instead of formally admitting you as an inpatient for administrative purposes. You were basically just in a very expensive waiting room. Time spent under observation does not count toward that mandatory 3-day inpatient requirement we just talked about, even if you were there for a week. If you or a loved one are ever in the hospital and it looks like you might need rehab afterward, you must explicitly ask the doctor or the hospital administrator this exact question. Am I formally admitted as an inpatient? Do not assume you are just because you're sleeping in a hospital bed. So, what happens if you don't need short-term rehab, but you actually end up needing long-term custodial care in a nursing home? Whether that's due to severe mobility issues, Alzheimer's, dementia, or just general decline, you are looking at massive sticker shock. The average nursing home in the U.S. now costs between $8,000 and $10,000 a month. Let that sink in. That is up to $120,000 a year, every single year. And remember the golden rule we established. Medicare pays zero for this. Nothing. Unless you qualify for Medicaid, which generally requires you to legally spend down almost all of your life savings and assets to reach poverty levels. Or unless you were proactive and bought long-term care insurance years ago, you will be paying this $120,000 bill entirely out of pocket. It's a brutal reality that completely drains family legacies. Section 4. Navigating care outside the U.S. So let's change gears a bit. What happens to your medical safety net when you travel? A lot of retirees love to travel, right? Well, the general rule of thumb is very simple. Once you cross the border and leave the United States, your Medicare coverage completely stops. However, there are 3 highly specific, extremely limited geographical exceptions to this rule. First, if you have a medical emergency while you are traveling through Canada, but only if you are on a direct route between Alaska and another U.S. state, you're basically just passing through. Second, if you have a medical emergency while you are physically in the U.S., but a foreign hospital, say right across the border in Mexico or Canada, is actually closer than the nearest U.S. hospital. In that rare case, they might cover it. And third, and this one is genuinely fascinating to me, Medicare may actually cover necessary medical services on a cruise ship, but there's a huge catch. The ship must be within exactly 6 hours of a U.S. port. If you are 6 hours and 1 minute away out in the open ocean, you're out of luck. Outside of these incredibly rare and very specific scenarios, you absolutely, for sure, need to buy supplemental travel health insurance if you are leaving the country. Do not rely on Medicare abroad. Section 5. Smart tax and financial strategies. Okay, take a deep breath. We've talked about a lot of uncovered costs and potential traps, but don't panic. Now, we are going to talk about how you can actually manage the burden of these out-of-pocket expenses. So, the crucial point here is understanding a very specific rule, the IRS medical expense deduction. If your unreimbursed medical expenses are high enough in a given year, you can itemize them on your taxes. The rule states that you can deduct the portion of your medical costs that exceeds 7.5% of your adjusted gross income or your AGI. Let's walk through the math together to make it really clear. Let's say your AGI for the year is $50,000, right? 7.5% of $50,000 is $3,750. That $3,750 is your threshold. Now imagine you had a really tough year health-wise. You spent $35,000 out of pocket on major dental work, buying new hearing aids, and paying hospital co-insurance bills. Because of this rule, you can deduct everything you spent above that $3,750 threshold. So you take your $35,000 in bills, subtract the $3,750 threshold, and that means you get a hefty $31,250 deduction to significantly lower your tax burden for that year. It's a huge financial life raft if you know how to use it. So what exactly counts toward this deduction? What can you put in that bucket to reach your 7.5%? Well, the IRS is actually pretty generous here. You can include those rising Medicare Part B and Part D premiums that are coming out of your checks. You can definitely include those massive Medicare gaps we talked about earlier, the out-of-pocket costs for hearing aids, false teeth, and eyeglasses. It all counts. You can include hospital service fees, and even the cost of transportation to and from your medical care. What about nursing homes? Yes, you can even include nursing home care, but, and this is a big but, only if the primary reason for being in the residence is to receive actual medical care, not just the custodial care we discussed earlier. The key takeaway here, by keeping meticulous receipts throughout the year, you can actually turn those painful uncovered Medicare coverage gaps into vital tax savings. Keep track of everything. We've covered a tremendous amount of ground today, haven't we? From the incredible new savings on negotiated prescription drugs and that $2,100 cap, all the way to the harsh $120,000 realities of the nursing home trap and the importance of observation status. Here is the final most important question you need to ask yourself right now. Medicare is clearly changing in 2026, but are you changing with it? You now have the facts. You see the board clearly. Take this opportunity to sit down and review your current plans. Double-check your long-term care strategy, talk to your family, and update your financial planning so that your health coverage works for you and not against you in the years to come. Thank you so much for joining me for this explainer, and remember to stay focused on both your health and your wealth.